Hello, my name is Ian Mathias, and my capstone is on the benefits of cardiac rehabilitation for prevention of second myocardial infarction and the effects of underutilization based on socioeconomic status. So some of the MPH competencies that were addressed in this capstone were to identify the causes of social and behavioral factors that affect health in individual populations, describe the role of social and community factors in both the onset and solution of public health problems, integrate and apply general biological and microbiological and parasitological concepts into public health research and practice, apply biological concepts in the development and implication of disease prevention, control, and management of programs, and lastly, to utilize evidence-based medicine concepts to inform public health policies and regulations. So this study briefly goes over the benefits of rehabilitation for myocardial infarction patients by comparing those post-rehab post-myocardial infarction patients in a rehab group versus those in the community setting who did not attend rehab. So we'll be looking at the mortality rates, the readmissions rates, and the reoccurrence rates of myocardial infarction. We'll also be looking at the underutilization of cardiac rehabilitation and how socioeconomic status affects the outcomes of post-MI patients. We'll also be going over how to improve on the rehab participation and alternatives to rehab when it's not accessible. So some of the methods and limitations were that this literature review was done using PubMed, ScienceDirect, and Medline Plus, as well as Hanari, to look up publications that were scientifically credible, such as scientific journals, publications, and trusted organizations, one being like the World Health Organization or the CDC. Some of the exclusion criteria were that all studies and experiments must have been published within the last 10 years. And there were 46 publications looked at total, but after the exclusion and inclusion, we analyzed 10 of these studies, and 15 of them were included as supporting articles. So in terms of the analysis, we would describe the results of each paper and then how they contribute to the arguments, as well as gaps in information. And then we will extract abstract ideas that could be drawn from the information presented in the study. Some of the limitations were that there were limited studies that specifically focused on the effects of cardiac rehabilitation on the incidence of a second MI. There was also most likely unforeseen bias and data manipulation within some of the articles that you just can't anticipate for. And then lastly, there is my own bias to take into consideration when writing this. So some of the benefits of cardiac rehabilitation. Typically after an MI, a cardiologist will recommend that a patient attends cardiac rehabilitation. The benefits to this are that there are fewer recurrences of angina and less hospital readmissions. So you could see that there's a reduction to 15% readmission rate to the previous 27% when comparing cardiac rehabilitation patients to those in the community. There's also an improvement in ventricular ejection fraction, and improvements on physical functioning, a decrease in body pain, general health perceptions are improved, social functioning is improved, as well as mental health, and improved quality of life overall, and overall physical ability. The cardiovascular-related mortality rate is also reduced from 30% to 18% over a 5-year period, which is a significant difference. So let's talk about the underutilization of cardiac rehabilitation. Overall, most insurance companies do cover cardiac rehabilitation, but some of the problem is that there's an increase in the amount of uninsured Americans. Currently, we're at 10%. The previous year, we were at 9%, and 2018, we were at 7.5%. So you could see that there's an increase in the amount of uninsured people in the US, and therefore they are less likely to be covered for cardiac rehabilitation. Now, for those that are covered for cardiac rehabilitation and are able to attend, only 36% of MI survivors attend cardiac rehabilitation. In this population, it's typically older adults, men, non-Hispanic whites, persons of college or higher education, and this is, from our point of view, it's kind of seen that if you have higher amounts of education, then you are more likely to see the benefits of the cardiac rehabilitation. So how is socioeconomic status a factor when looking at MI patients and their outcomes? So initially, the incidence rates for MI and the rate ratios for lower income and middle income individuals was 1.67 and 1.87 respectively, and that is compared to high income individuals. And then when I'm looking at the 28-day and 1-year mortality rate ratios of MI patients in lower and middle income individuals, it's 3.18 and 2.33 compared to higher individuals. Attendance rates of cardiac rehabilitation are also much lower in the lower socioeconomic status patients. So overall, we have a low participation rate in the general population of people that should be going to cardiac rehabilitation, and this percentage decreases even further when looking at lower socioeconomic status individuals. So strongest predictors of non-attendance are the distance they live from the nearest cardiac facility, whether the individual smokes, if they have a higher burden of comorbidities, and their unemployment status. And if you look at these predictors, you'll see that a lot of them are common in low socioeconomic status populations. Smoking is much more prevalent within socioeconomic status populations, and typically low SES people live further away from resources such as cardiac rehabilitation centers, and is well established that they are far away from accessible food. We know of food deserts, and that's just a few of the examples. So overall, it's more common for low socioeconomic status to have these risk factors. So not only do they have greater risk factors for acute MI prior to the first MI, the low socioeconomic status patients are 2 to 4 times less likely to change their lifestyles and modify their risk factors following an MI. So why is this important? So cardiovascular disease is the leading cause of death in the United States and one of the top causes of death in the world. According to the American Heart Association, about 17.8 million deaths in 2017 were attributed to cardiovascular disease. For MI patients in the United States, there were 1.5 million new cases each year. And the reoccurrence in these patients is 27.5%. So not only is there 27.5% reoccurrence, but the mortality rate significantly increases. There's a hazard ratio of around 1.5. So if you have a second myocardial infarction, you're much more likely to die compared to your first incidence of myocardial infarction. So it's very important that we prevent this second case from happening using cardiac rehabilitation. Now, one way we could do this is by improving the accessibility and the percent of participation. And another thing worth noting is that cardiologists do understand the benefits of the primary and secondary prevention of cardiovascular disease, but it's found that most of the time they're not really effective in getting the message across to patients, so they don't fully comprehend that it's important for them to attend. So how should we improve this? So one way to do this is the main thing we should focus on is increasing the attendance, which would decrease the mortality rates, and it would also highlight the benefits of cardiac rehab if we could show this data. If we could show that patients are benefiting from this, then maybe people will be more likely to attend. We could also utilize, it's also been shown to utilize electronic medical record-based prompts and staffing liaisons to increase referrals to cardiac rehabilitation centers for those that would benefit. Home-based telemonitored cardiac rehabilitation has also been shown to be equally effective, but also more cost-effective, and there's a higher patient satisfaction afterwards. We could also look at things such as yoga. Studies are looking into yoga as a more cost-efficient and accessible way of therapy, and its effectiveness is currently being studied on acute myocardial infarction patients. And then lastly, the family and social support systems may play a significant role in the patient's attempt to recovery. I think it would be very valuable to check out the, to study the effects of family and social support in cardiac rehabilitation patients versus the population that doesn't have the same support or even the attendance rates. So that would be very good to look at. So in conclusion, cardiac rehabilitation has significant benefits for patients of acute myocardial infarction, but despite the proven benefits of cardiac rehab, there's a high accessibility. There's only 35% participation in patients with acute MI. People of low socioeconomic status have greater risk factors for acute MI, higher first-time incidence rates, and less access to cardiac rehabilitation. And they also have lower attendance rates when accessible. So there needs to be more efforts in expanding the general accessibility in cardiac rehabilitation to the population. And there also needs to be better education for all cardiac rehabilitation patients, or for all cardiac patients on the benefits of attending, as well as making it easier and more affordable to access the benefits of cardiac rehabilitation through offsite resources. So that way that if they are out of range of a cardiac rehabilitation center, they're still able to access these benefits. So these are my references, and thank you very much for your time. Hope you enjoyed.